Hi everybody, welcome to Common Adult ECGs, Adult Electrocardiographs. This is part 1. The purpose of all these ECG workshops are essentially to assist you to identify cardiac dysrhythmias and cardiac arrhythmias. And remember, what was common in pediatrics, if you reviewed the pediatric component, is uncommon in adults and vice versa. Pediatrics develop cardiac arrhythmias and dysrhythmias for different reasons compared to adults. Now, the objectives for this part 1, are to review your knowledge first of all, review some basic cardiac anatomy and physiology to make it a little bit more interesting, then look at cardiac electrophysiology and the electrical axis in an adult. So what do you know? Let's see. Which of the following is the normal pacemaker of the heart? A, B, C, or D? The correct answer is A, the sinoatrial node. Which of the following are all components of the conduction system of the heart? A, B, C, or D? The correct answer is all. All of them are components. Which one of the following statements represents the P wave? A, B, C, or D? The correct answer is D, atrial depolarization. Which of the following statements then relates to the sympathetic nervous system? A, B, C, or D? The correct answer is all of the above relate to the sympathetic nervous system. Which of the following statements about normal heart rate is correct? A, B, C, or D? The correct answer is A, 60 to 100 beats per minute. Which of the following relates to the parasympathetic nervous system? A, B, C, or D? The correct answer is D, all of the above. Which of the following statements refers to standard ECG leads? A, B, C, or D? The correct answer is all of the above. Number 8. Which of the following relates to sinus tachycardia? A, B, C, or D? The correct answer is none of them do. None of them relate to sinus tachycardia. Which of the following then connects to atrial fibrillation? A, B, C, or D? Atrial fibrillation relates to all of the above. Which of the following then correlates to a premature ventricular ectopic contraction complex? A, B, C, or D? The correct answer is D. All relate to PVCs. Can you name the following ECG anomaly? These are premature ventricular complexes. What about this one? This is supraventricular tachycardia, abbreviated to SVT. What about this anomaly? This is coarse ventricular fibrillation. How about this one? This is asystole. Can you name this ECG anomaly? This is atrial fibrillation with a controlled ventricular response. So let's begin. Let's have an overview of the anatomy and physiology. Approximately 18 to 21 days post-conception, the heart actually begins to function in the developing embryo. During this stage, the heart begins to beat at a rate of approximately 70 to 80 beats per minute because hemopoiesis, red blood cell production, has already commenced. The circulation requires pushing. And this is where the heart starts to become what we know as the heart, with the fusion into the primitive heart tube. And it's interesting to note that a human heart beats approximately 3.5 billion times in a normal lifetime. Then at about 35 days post-conception, the heart's starting to look, as we already know, with its great vessels, and the conduction system is already developing and becoming more mature, evolving. At about 52 days post-conception, the inside of the heart and the outside of the heart and the conduction system are almost complete, as we know it in a full-term infant or adult. At 40 weeks, heart rate is approximately 130 beats per minute at rest, no fetal distress. At term and at birth, these are some of the normal cardiac details. The heart is normally located in the thorax, the mediastinum, which is the cavity between the lungs. The base is at the level of the second intercostal space, and this is where the great vessels exit. The apex is located at the fifth intercostal space in the midclavicular line, immediately above the diaphragm, which the heart sits on. The weight of the heart at birth demonstrates right ventricular dominance. The left ventricle is small compared to the right ventricle in relation to the ratio. And the size, right ventricular dominance again, the left ventricle is only 1/4 what the right ventricle is. Because in the fetal circulation, the right ventricle has to work really hard, the left ventricle does not. Once the infant is born, the left ventricle over the next 3 to 5 years has to work very, very hard, and it establishes dominance. The electrical axis at birth is right ventricular dominance. And the right axis is approximately 90 to 180 degrees. And the heart rate and the left ventricular demands increase after birth. Because as I said, the left ventricle really has to start working now, whereas in the fetal circulation, it didn't have to work too hard at all. The right ventricle only has to pump blood to the lungs once the infant is born. The left ventricle has to pump blood all around the systemic circulation. The adult heart then demonstrates left ventricular dominance. And it's got a weight ratio now of 2.5 to 1 compared to the right ventricle. And the size is now 5 times larger than the right ventricle in proportion. We have 2 cardiac cycles. This is the one that we're reviewing here today, the electrical cardiac cycle. And you need the electrical cardiac cycle to stimulate the myocardium to provide the mechanical cardiac cycle, which is to do with systole, emptying of the heart, and diastole, which is to do with filling of the heart. The cardiac conduction system consists of the SA node, the sinoatrial node, the atrioventricular node, and in between those two nodes, the atrial pathways. Below the AV node is the His node, which is followed through by the bundle branches, right and left, which bifurcate into the Purkinje fibres. The SA node is also known as the node of Keith and Flack, which was discovered in 1907. the intra-atrial pathways, which were discovered in the early 1900s by Bachmann, Wenckebach and Thorell. The AV node, discovered by a Japanese physiologist, Tsunoya Tawara, in 1906. A His node, discovered by Wilhelm His in the late 1800s. The Purkinje fibres, named after Jan Purkinje, in the mid-1800s. This is the cardiac conduction system. SA node, intra-atrial pathways, AV node, His node, bundle branches, and Purkinje fibres. When we look at the SA node, the sinoatrial node, is referred to as the inherent or the intrinsic pacemaker. It's sited in the subepicardium at the junction of the superior vena cava and the right atrium, and it depolarizes at rest in the adult between 60 and 100 times per minute. The intra-atrial pathways connect from the SA node. They are Bachmann, Wenckebach and Thorell, and they have a depolarization speed of about 1,000 millimeters per second, which means the electrical current is delivered to the atria very, very quickly. The intra-atrial pathways essentially connect to the AV node. The AV node is also known as the secondary or the backup pacemaker, just in case something happens to the SA node. And the SA node, as we said, at a speed through the intra-atrial pathways of around about 1,000 millimeters per second, but when the current gets to the AV node, it slows right down to 200 millimeters per second. And the purpose of that is to slow conduction to give time to the atria to contract and empty their contents into the ventricles. Now the AV node is sited at the atrioventricular junction. And it depolarizes at rest approximately 40 to 60 times per minute. In the His-Purkinje system, which I've labelled as the tertiary or backup pacemaker, which really it isn't, the only pacemakers really under normal circumstances are the SA node and the AV node. But in some instances, the His-Purkinje system can become activated and provide backup, but if it does, it depolarizes very, very slowly, between 20 and 40 times per minute. It's sited in the subepicardium, in the ventricular septum, which branch off into the bundle branches and eventually become the Purkinje fibres in the myocardium. However, the Purkinje system has got a very, very fast speed of about 5,000 millimeters per second because it has to depolarize or stimulate electrically all the myocardium at exactly the same time to provide synchrony, which means the right ventricle and the left ventricle have to contract at exactly the same time together in order to provide an effective cardiac output. Let's review some of the history related to electrocardiography, and it's brief. I haven't included absolutely everything. However, it was Willem Frans Einthoven in 1901 who invented the ECG machine, referred to as the EKG machine in German. And he recorded right, left arm currents from the heart and from the foot. And he named them the PQRST waveforms. And he didn't name them for any particular reason. He just had no choice. Initially, he wanted to call it 1, 2, 3, 4, 5. And then he decided A, B, C, D, E. But the scientific community said he couldn't do that because already these numerics and these alphabetical figures had already been taken by other scientists. What was left for him was PQRST, and anything thereafter. He chose PQRST, and this represented certain components of the ECG, which we'll discuss later. In 1934, Frank Wilson, an American, created the standard leads, which were referred to as VR, VL, VF, lead 1, lead 2, lead 3, and he also is responsible for creating the precordial leads, or the chest leads. V1, V2, V3, V4, V5, V6, also referred to as C1, C2, C3, C4, C5, C6. And these standard leads, VR, VL, VF, are also referred to as unipolar leads. Lead 1, 2, 3 are referred to as bipolar leads. The precordial leads are unipolar leads. Unipolar leads just record current in one direction. Bipolar leads are a combination of two electrodes, so therefore recording in two directions, which we'll discuss at a later point in time. Emanuel Goldberger in 1942, he increased the voltage on the ECG machine by about 50% so that we could see a bigger ECG complex on the recording instruments. And this is where it became, AVR became AVR, AVL and AVF. The A just stands for augmented, made bigger, on the ECG or the galvanometer. Here are some electrophysiological concepts that we need to consider as well. First of all, we have depolarization. And depolarization is seen first of all as an action potential for one cell. That's the small ECG that you see at the top. The big ECG down the bottom combines millions of action potentials which form the big ECG, if you want to think of it like that. And depolarization basically represents sodium going into the cell. D is actually Latin for change, so we have depolarization, which changes the polarity which can be measured. Depolarization then on the big ECG, which we're talking about, which is many action potentials, can be atrial depolarization and can be ventricular depolarization. Atrial depolarization is represented by the P wave on the ECG, and ventricular depolarization is represented by the QRS complex. Then you have repolarization, which means going back to the way it was before depolarization. And this is where sodium and potassium move out of the cell. And this is an action potential that you're seeing. And there are 4 components to it, which you can review at a later point in time. But this part of the ECG, or action potential, creates this on the big ECG. Ventricular repolarization. And ventricular repolarization is represented by the ST segment and the T wave. And the ST segment essentially, simply represents early repolarization of the ventricle, and the T wave represents later repolarization of the ventricle. Now, I don't mention it here, but we do have atrial repolarization. And atrial repolarization is represented by the TA wave. You can look that up, Google it, and you can see what I'm talking about. When we comprehend electrical access in the adult, we have to first of all think of basic components. And if you've got current going to an electrode, this creates a positive deflection on the ECG. This could be a positive P wave, or a positive QRS complex, or a positive T wave. Going away from an electrode creates a negative deflection on the ECG. So therefore, a negative P wave, or a negative QRS complex, or a negative T wave. if you've got current going to the electrode both from a positive and a negative direction, which is typically at 90 degrees to that electrode, it can create a biphasic deflection, which means positive and negative. And this can be positive P wave, it can be positive and negative, it can be a positive and negative QRS complex, it can be a positive and negative T wave. It just indicates to you where the current is going to in relation to the electrode. Einthoven, as I said, in 1901 created the right arm electrode, left arm electrode, and the leg electrode. And Einthoven's triangle basically represents this. Think of it like this: right arm electrode, left leg electrode. And if you've got current going away from the right arm electrode, it creates a negative ECG component. If it's going to the left arm electrode, most of it is going down away to the left ventricle in the adult, so therefore it's seen as going away negative, a little bit going towards the left arm electrode. So you've got a biphasic deflection, a little bit positive, mostly negative. If it's going directly to the left leg, it's mainly positive. So these are called your unipolar leads: AVR augmented, AVL augmented, AVF augmented, which Einthoven didn't augment it. It was Frank Wilson in 1934 that augmented the leads. However, these are unipolar leads. And he then created a way to now use two together, AVR and AVL, created lead 1. So together they create a biphasic deflection. Combining the left arm and left leg electrode creates lead 2, another bipolar lead, which is primarily positive because it's heading towards the left side of the heart under normal circumstances. Then you've got the right arm electrode and left leg electrode, which creates lead 3. And lead 3 is a biphasic electrode. It's not typically that positive, but it can be. Depends on the position of the heart. So AVR, AVL and AVF are your unipolar leads, recording current from the heart in one direction, and lead 1, 2 and 3 are bipolar leads which are created from your unipolar leads. So essentially these are your 6 standard limb leads. If we take it a step further, Einthoven's triangle can be converted into what is called the hexaxial reference system. And this looks at 6 electrical views of the heart. And it can be measured. You can provide degrees to give you an indication of where the current is going and where it has come from. So this is referred to as the frontal plane axial system. And essentially what it does, it looks at the current from the right to the left, from the top to the bottom. Right to left, superior, inferior, and it has numerics associated with it. And there are 2 poles, a negative pole and a positive pole. If we look at AVR, AVR is primarily going away from the electrode. So we see AVR always, under normal circumstances in an adult, is always negative. Every part of it, the P, QRS complex, T wave, always negative. If it's going to AVL, it'll be biphasic. If it's going to AVF, it will be positive. Because in an adult heart, the left ventricle exerts the most influence on the ECG, because it's 5 times larger than the right ventricle. So therefore, in relation to the atria, it's a lot bigger. Then you've got lead 1, which is a combination of 2 leads, as we said, and it will be biphasic. Then you've got lead 2, which is a combination of another 2 leads, and it will be primarily positive. It's actually the best lead that we choose to monitor in a normal adult with left ventricular dominance. Then you've got lead 3, which is positive, but typically it isn't as positive as lead 2. They almost look identical. Lead 3 will be more negative, but again, it can vary. Everybody is different. These are your 6 leads in the hexaxial system, and they all have figures associated with them. So for example, if we looked at it now, we would say AVR is normally minus 150. AVL is normally minus 30 degrees. AVF is normally plus 90 degrees. Lead 1 is normally 0 degrees, perpendicular. Lead 2 is normally plus 60 degrees, and lead 3 is normally plus 120 degrees. In a normal adult, which can vary depending on the electrophysiologist that is giving the information, but as a general rule, typically in a normal adult, the degrees are from 0 to plus 90 degrees because of left ventricular dominance. The left ventricle dominates the ECG complex. So when we look at this slide here, we can see that lead 2 is the most positive for the reason that we said, because again the current from the left ventricle being depolarized is heading straight towards lead 2. So lead 2 is considered the best monitoring lead in most normal adults. What are the normal heart rates for a typical adult? Well, resting 60 to 100 beats per minute, as we said, SA node. Anything less than 60 is considered a bradycardia or slow. Anything faster than 100 is a tachycardia or fast. Anything faster than 160 is considered to be, possibly, not always, a supraventricular tachycardia. Right, that ends part 1. So, thanks. If you found this of any value to you, move on to part 2.